Morning, everyone. I'm one of the spine fellows at SDSF. Today, we'll be doing our talk on managing surgical site infection and early complications. It's not the most glamorous talk, but as you'll see, it's important because unfortunately, these can and do occur. I'm going to try and go through this systematically, touching on the epidemiology, the pathophysiology, how these are classified, how we prevent them, and then finally, and most importantly, how we treat them. So unfortunately, no matter how many mitigation strategies we use, SSIs are still do occur among any surgical practice in the world. It's the third most common complication in spine surgery. And the papers vary tremendously. Some studies have reported down to 0.2% all the way up to 16% for complex multi-level fusions in an outreach setting. And of course, this results in suboptimal outcomes in terms of readmission, patient-reported outcome metrics, which we'll talk about, and further cost to the system. And unfortunately, this does result in mortality as well due to progression of the disease and dissemination by septicemia and other causes. So numerous studies have looked at this and really have tried to narrow down which patients are at the greatest amount of risk for developing these. This is one from the National Healthcare Safety Network here, published in Red Journal, where they were looking at trying to identify, for example, time of operation, and they identified 2 hours and 46 minutes for decompression, about 4 hours for fusion operation, at which the risk of SSI goes up. And then looked at other things such as ASA score and wound classification. When they looked at the odds ratio for a lot of these predictors, what they found was that things that we are well aware of, like diabetes, obesity, a revision operation, smoking, and previous infections like UTI, as well as dural tear and age, were significantly predictive. This was another paper that came out looking at nutritional status, and it's something I think that's gaining more traction in the literature by looking at preoperative albumin. There have actually been numerous database studies looking at this. And this group here identified it as another predictor of postoperative SSI. And unlike numerous of the ones we looked at in the previous slide, this one can actually be potentially modified. And as we all know, we really try and modify risk factors as much as possible prior to recommending surgery. In terms of outcomes, like we just touched on, unfortunately, they're significantly decreased in all domains. This is just a paper in spine looking at patient-reported outcome metrics among patients who developed an SSI compared to those who didn't after spine surgery. And they found that while ODI and SF36 improved across both groups of 2 years, folks who'd had infection had increased back pain, potentially, of course, due to osteoporosis, but other causes. And then subsequently, they actually had a decreased percentage of those who met their patient-reported outcome metrics for things like ODI. This is another case control, the prospective study, prospectively collected, and then they looked at different subgroup analyses, looking at the effect of deep wound infection in lumbar fusion at long-term patient-reported outcome metrics, and they found that 53.8% of those who developed infection were actually not satisfied compared to those. And obviously, if for any type of surgical intervention, we really want to see if patients, are happy that they had the operation in the first place. So these are red flags and shows this is something that's very important to avoid and mitigate as much as possible. Looking at other outcomes between open and MIS, this group reported a very low rate of infections at 1.5%. But they suggested that using MIS techniques did result in decreased infection rates, potentially due to they hypothesized less blood loss, shorter operation, and shorter postoperative hospitalization stay. In terms of pathogenesis, a lot of these infections typically occur, it's thought to be due to direct entry of bugs from the skin flora during the operation. And of course, that premise drives a lot of our mitigation strategies, our prep techniques, alcohol swabs, sterile technique. Most common skin bacteria are coagulase negative staph, propione, and crying bacterium. But the most common cause of SSI is Staph aureus, as we know, which results in about 50% of cases. And of course, for those who have been hospitalized or getting revision surgery, MRSA becomes a significant bug for a lot of these cases. Staph epi accounts for about a third. And then, of course, gram negatives like Enterococcus are found in about a third as well, especially in lumbosacral operations due to proximity to the GI tract. There's a classification. There have been lots of different papers looking at infections in several different ways. This was a multi-center retrospective review. This is an older study, but they looked at different groups of patients, essentially trying to stratify risk. So they call group one a single organism infection. That was either superficial or deep. Group two is multi-organism and deep. And group three had several with evidence of myelonecrosis. And similarly, they classified the hosts and the patients into three groups. Two, A being folks who had normal defenses and didn't have diabetes. B had certain comorbidities like smoking, diabetes, heart disease, things like that. And the third group had patients who are immunocompromised or malnourished, like we just talked about, or patients in multi-trauma situations. And what they found was folks in group one really largely got by with a single IND and closure over a drain. And then patients in this group two category needed multi-stage irrigation debridement, multiple wound vacs before attempting a primary closure. And group three was very challenging to manage and had suboptimal outcomes, unfortunately, regardless of technique. It's just a video, unfortunately, kind of showing what we see as we treat these folks and try and collect these specimens. And these deep infections that track below the fascia to the instrumentation are really, really quite impressive when you open these up. So all this feeds into the next topics, which is prevention, something that we're all trying to focus on. And there have been numerous studies. I'm trying to be really literature-based in this talk because I think no two surgeons I've ever worked with in my training have done the exact same mitigation techniques. Of course, the first is optimizing patients before they have surgery in terms of risk factors for things like metabolic disease. So this paper looked at folks with type 2 diabetes, and they tracked patients' A1C values, and those less than 7 had no infections, and those greater than 7 had a substantial amount, over a third. And then, of course, smoking, something we check for, especially for in terms of fusion, but it's also relevant for infection. This is another paper here by this group looking at increased risk of infection in smokers after spine surgery. And then in those who successfully stopped and were demonstrated to have stopped, that risk went down. The odds of developing an infection went down by over 50%. But interestingly, they found that if you just stopped for a month prior to surgery, that did not affect SSI risk. There's something about longstanding systemic, either immune function or some other variable that's impacting this. Obesity, of course, something we look at in all medicine, but in spine surgery too. This is a paper looking at infection risk in folks with BMI greater than 30, and they found that their odds were greater than 2, increased odds of developing infection. And then another factor we always look at is carrying staph, especially MRSA. And of course, that's the premise behind swabbing patients' nasal passages for MRSA before surgery. This one looked at an RCT of staph carriers who were treated for it versus a group that did not. And the ones that did not had greater than twice the rate of postoperative SSI. Of course, skin prep is something that's universally done in spine surgery. There have been many studies comparing ChloraPrep and DuraPrep, and the literature is mixed, with some studies in favor of each and some showing no difference. Surgical gloves, another factor. As we know, several of our surgeons will swap gloves at certain time points, and a lot of that's driven by culture data and actually even some clinical data. This is a study here with 179 patients where they looked and found after practice change that Removing the outer pair of gloves prior to handling the instrumentation resulted in decreased rates of SSI compared to just keeping both pairs and the double glove on the whole case. This was a paper in the Red Journal they essentially implemented a practice change of including chlorhexidine showers, and they looked at infection rates before and after this practice change, and they found that the rates of SSI significantly decreased after they implemented this protocol. But there are some different studies that looked at the same thing and unfortunately did not find any difference there. Other techniques in the operating room, we've seen folks, use betadine. Betadine soaks, and there have been numerous studies looking at that. Some showing decreased rates of deep wound infection after implementing this. But the literature, again, is really mixed. A lot of these are single center retrospective analyses with significant selection bias, and the literature is limited in terms of quality prospective level 1 data. Some folks have looked at antibiotic and impregnated sutures, and they showed some reduction in SSI rate, and some, unfortunately, have not. This was a systematic review, was published back in 2022 that looked at iodine irrigation solution compared to control group. And they had almost 3,000 patients in their cohort. And their combined results showed a rate of 1.8% of superficial infections in the treatment group compared to almost 5% in the control group, with an absolute risk reduction of 2.8%. And of course, different irrigation systems exist. Some people use ANSEF. Of course, we have Irricept here at Scripps, and this literature continues to evolve. This was another review that was looking at chlorhexidine irrigation that was showed to reduce infection in different types of operations, ranging from abdominal to pelvic to knee surgery, and now extending to spine. In terms of treatment, with hydrogen peroxide, there's some data here showing that hydrogen peroxide soaks provided decreased rate of SSI without a significant difference in complications. So another option, something that's done at certain centers. And then, of course, vancomycin powder has been studied extensively, especially in fusion operations, and something that has been shown to reduce infections and is widespread use today. In terms of post-operative care, different studies have looked at different things. Of course, we at Scripps use these Aquacel silver impregnated dressings. This is a study that they did with 230 patients looking at a comparison of silver impregnated dressing compared to normal. And interestingly, in the ones that got the silver dressing, among the 106 patients who received that, there weren't any cases of infection compared to 3 deep and 11 superficial in the control group. Wound vacs, of course, something that we do for a lot of our larger cases with larger skin incisions here. That's been looked at numerous studies showing a significant reductions in SSI with 5 days or more of wound vac therapy. Post-operative antibiotics, I think the landscape has evolved as well over the last several years. This is a systematic review, actually, that looked at both really high-quality evidence, 9 RCTs, and lower quality evidence in terms of retrospective cohort studies. And they interestingly found that continuing post-operative antibiotics was not found to reduce the rates of SSI, especially after 48 hours. And whether or not patients had a drain did not affect this outcome. It's interesting because when I started my residency, actually, numerous surgeons would continue IV antibiotics in all patients who had a drain placed and have since actually adapted their practice because the data has come out demonstrating this now. Different things like ERAS people have looked at did not really seem to reduce the rates of SSI in spine surgery. So in terms of treatment, obviously the gold standard is irrigation debridement, right? It's for both obtaining a diagnosis in terms of having a culture to target your antibiotics with and narrowing from broad spectrum, debridement of tissues that are contaminated, and then getting some type of durable closure so that patients can heal these. And different studies that looked at different types of protocol and trying to predict who can be treated more conservatively in terms of one IND with debridement compared to uh, multi-stage debridements involving plastic surgery for flap rotations, things like that. This study looked at 225 consecutive patients with SSI, and they were treated with an IND and antibiotic therapy, and they defined the treatment success resolution at the 90 days. And 76 of these patients actually retained their implants, and about a fifth had treatment failure, unfortunately. And these authors tried to identify the groups of patients that were associated with reduced treatment success, and they found that late infection, fusion to fixation of the pelvis, so patients with deformity or long segment trauma, um, those who had propionibacterium infection, or polymicrobials, and then larger cases with over 5 levels. And of course, instrumentation cases, where the thought is that you can have biofilm formation on those implants that drives this pathophysiology. Conversely, they found high rates of early resolution with superficial infection, patients who had just MSSA as opposed to MRSA, and shorter segment degenerative cases. And on multivariable logistic regression, they found that a delayed infection was the most significant independent factor associated with treatment failure. This is another paper that really tried to build a model that stratified patients with infection to try and identify who would need multi-staged irrigation debridement operations. And they looked at over 30 different variables to try and create this prediction model. And they identified, similarly to the literature that we already talked about, that folks with MRSA, a distant source, so not just skin spread, but hematogenous spread for things like dental infection or pulmonary infection. Presence of implants, of course, posterior approaches, the use of non-autograft bone graft, and systemic disease such as diabetes were predictive of needing multiple irrigation debridements to avoid failure. There have been different types of algorithms that have been proposed. Like we talked about, really the mainstay long-term therapy is antibiotics for both patients who undergo surgery and those who can avoid surgery. And these authors identified folks with neurologic deficits, of course, where you have some type of phlegmon that's compressive, sepsis, because those patients need source control. If they're hemodynamically unstable secondary to a spinal infection, you have to treat the source as quickly as possible. Spinal instability and or deformity for infections that, for example, spread to the upper instrumental vertebrae and cause bony instability. And then failure of non-operative measures. So progressive deformity, bony destruction, elevated biomarkers like CRP despite best treatment. And looking at the different treatment protocols, they talked about the variables that we discussed, which is attempting medical management, folks who don't have a deep infection or hemodynamically stable and not septic. And of course, in those patients, it's really important to still get a culture and try and identify a diagnosis. And those who get surgery, they get probably the most robust culture data and specimen data because we can go to the operating room and remove all this infection, send it out for analysis. And after obtaining adequate irrigation debridement, either single or multi-stage, continuing those antibiotics, typically in conjunction and consultation with our infectious disease colleagues. I included a whole host of references here. Thanks very much.
Nice job, Nikita.
Yeah, thanks, Nikita.
Big topic.
Thanks.
What sort of things is reflecting so far? You've seen some infections. What sort of things are you taking away from this Scripps experience?
It was interesting you asked. So some of my friends at other centers have asked me that too. I think there are a couple of things. I think a lot of the surgeons are very meticulous about 2 Erocept uses throughout the case, which is a very potent antimicrobial. Meticulous prep. Some surgeons, for example, Dr. Mundus will actually prep the skin both before surgery and actually after when he's already putting the staples in. I think speed. Several of the papers here have shown longer surgical times are associated with infection. Of course, there may be founders there, but generally, the folks with scripts are very fast and have lower operative times, I'd say, than the national average. I guess they.
Just to quickly comment too, we actually did a study at HSS when I was a resident. We looked at use of vancomycin versus Ancef because we had a lot of patients who are, penicillin allergy and stuff like that. But the infection, and we looked at it kind of similar to how we look at it in like total joints and stuff like that, because there really hadn't been a study that looked at directly like Ancef versus vancomycin and found that patients with vancomycin, antibiotics were 2.5 times higher to have infection, postoperative infection. That's all types of spine surgery, but 2.5 times higher to have infection versus just Ancef. So I think it's really important also if you can press your anesthesiologist to, either pre-test or, treat, any minor kind of penicillin allergy, but to really push them to use Ancef is really important too in preventing infection.
That's a standardized thing here.
Yeah.
So that is helpful. I mean, number one on the prep, which I want to say is overlooked too much, because you can't control your speed. I mean, sorry what you are, you get better in time, but your speed of surgery may not be addressable. So think about modifiable risk factors. Really be diligent about prepping patients preoperatively. The nutritional status, get pre-albumins, look at their total lymphocyte count, the things that we know from the total joint literature. You guys are just privy to a neurosurge, but really do a standardized, diligent job at that prep of patients. So you catch those that are really at risk. I think that's something we've done a lot better job at that we didn't do so great a job at previously. Mm-hmm. And some of it's been force fed, the hemoglobin. See now the hospital comes down on you if you're operating on them and they're over 7.5. But if you can make your process like on our bed reses, mm-hmm. all the standardized labs, mm-hmm. and you clear that, it'll make a big difference. Mm-hmm. The other thing in your talk that, and this is more from the paper, but MIS, my sense is that it's got an incredibly low infection rate because of the tissue damage more than anything. It's definitely not faster. I think it comes down more just to the tissue assault that they don't go through, whether it's deformity or TGen. So you're not immune, but it's an incredibly low rate relative.